Okay, guys, I have your C for you tonight. We're discussing interprofessional and holistic care. Okay, here we go. This heading introduces a model of end-of-life care in long-term care facilities that is deliberately interprofessional and holistic rather than focusing narrowly on medical treatment. It integrates multiple disciplinaries to address the full spectrum of resident needs: physical, emotional, spiritual, social, and practical. The approach emphasizes person-centered care, ensuring that interventions align with the residents' values, goals, while also supporting families through anticipatory guidance, caregiving, and bereavement. Core elements of a holistic interprofessional approach: whole person focus. Care extends beyond symptom management to include emotional support, spiritual care, life review, legacy projects, and attention to social detriments such as finances, housing, stability, and caregiver capacity. Goal concordant care. Structured conversations elect residents, values, preferred place of death, and acceptable trade-offs. These are documented and guide all team actions. Continuity and coordination. Shared care plans, warm handoffs, and consistent messaging across disciplinaries prevent fragmentation, and reduce burdensome transitions. Family and caregiver support. Families receive education on what to expect, practical skills for bedside comfort care, respites, options, grief and bereavement follow-up, equity and cultural responsiveness. Care practices adapt to residents' cultural, faith, and community context, ensuring rituals, communication styles, and decision-making norms are respected. Team roles in long-term care: nursing, daily monitoring, symptom assessment, medication administration, and coaching families in bedside care. Physicians, nurse practitioners, physician assistants, prognostication, deprescribing, aligning treatments with resident goals, and coordinating hospice services. Social work, values, education, conflict mediation, caregiver needs assessment, resource navigation, and bereavement support. Chaplain, chaplain and spiritual care, rituals, meaning making, faith consistent guidance and support for staff and family moral distress, rehabilitation, PTOT, SLP, comfort focused mobility, safe. Safe positioning, dysphagia strategies, and adaptations to preserve dignity. Psychological and mental health, coping skills, trauma-informed approaches, and support for anxiety or depression. Pharmacy, pain and symptom regimens, deprescribing, and monitoring medication burdens and benefits. Administration, policies, staffing, data tracking, and partnerships with hospice and community organizations. Practices adapted for LTC settings. Early identification. Triggers for palliative review include functional decline, frequent infections, weight loss, and increased distress. Care conferences. Structured family meetings with shared decision-making tools and clear documentation. Symptom pathways, standardized protocols for pain, dysphagia, and delirium, nausea, let's see, putinitis, and terminal secretions, supported by rapid response kits. Comfort first environment, quiet spaces, flexible visitation, culturally meaningful rituals, and privacy for family gatherings. Communication norms, plain language updates, tech back methods, and consistent messaging across shifts, care plan, flags for comfort focused status. Hospice integration, clear eligibility reviews, contracting and seamless transitions to hospice within LTC. Staff support debriefs morale, distress, resources, and grief. Acknowledgement to sustain compassionate care. Equity and culturally responsiveness. Culturally adapted ACP tools, translated plain language, materials and virtuals, community informed scripts, rituals and preferences, space and time for faith practices, music, foods and dress, and family led caregiving roles, decision-making models, inclusion of extended kin, communal leaders or faith, advisors where preferred, respected for collective consent norms. Barrier reduction, transportation vouchers, financial counseling, and flexible scheduling to enable family presence, transparent policies or practices, address mistrust rooted in historical harms, language access, professional interpreters, and culturally coordinated staff whenever possible, outcomes and evaluation. Clinical outcomes, reduced burdensome transfers, improved symptom scores, fewer non-beneficial interventions, and hospice utilization aligned with resident goals. Experience measures, resident and family satisfaction, perceived dignity, spiritual well-being, and quality of communication. Process matrix, timeless timelines of care conferences, documentation, completeness, adherence to symptom pathways and equity indicators, discrepancies in hospice access or ACP, learning loops, regular case reviews, and participatory feedback, refine protocols, close equity gaps, quick takeaways, an interprofessional approach to holistic end-of-life care in long-term care settings describes a coordinated, culturally responsive, whole person-centered model. It aligns treatment with resident values, optimizes comfort, supports families, and builds systems for continuous improvement This framework ensures that end-of-life care in LTCs is not only medically uh, complement, but also deeply humane, equitable, and community informed. Would you like me to map these elements into a practical toolkit format like checklists or care conference templates that could be directly applied in LTC practice? Okay, guys, that's your C. I will see everybody later for show, maybe tonight, later. For now, Gator Wellness, take care, folks.